Next case is a fascinating patient with surprisingly weak zonules and lens mobility, needing a triple procedure, DSAEK, endothelial keratoplasty for Fuchs corneal dystrophy. Has a very shallow chamber, short axial length, hyperopic eye, and you can see the wrinkles in the anterior capsule here, so showing how weak the zonular support is. And you can see that there's an absence of zonulars to the right of the screen there as the chamber deepens. Anyway, so I'm going to go ahead and do a very slow, meticulous capsulorhexis here under viscoelastic. Just going to go ahead and try and make it fairly generous because of the zonular weakness. I tend to try to make a little bit larger rhexis and then a little bit more aggressive hydrodissection. Might even do that POP procedure because of zonular weakness. I'm trying to use a one-handed technique here, a phacoemulsification, to dissolve the lens nucleus. I'm not so worried about the endothelium since I'm going to replace it. I'm much more worried about the capsule and the weak capsular support. So I'm keeping maximum occlusion here. A lot of it's bevel down technique to keep that occlusion. So I'm removing all the lens here, and this is relatively easy. The next part though is a little bit hard because the cortex is fairly adherent to this loose bag. You can actually see up there to the upper right of your screen that the zonules are quite weak in that area. So I'm avoiding that area, and I'm just going to do a very meticulous and careful cortex removal. And I've decided at this point, I've asked the technicians and nurses to get a endocapsular tension ring so that I can get a little bit better support. But I'm going to go ahead and just gently remove this residual cortex material with the irrigation aspiration unit. You can see this is the weakest area in the zonules. That's full indentation there of the capsular bag. So just trying to keep gentle occlusion, just enough vacuum to purchase and hold on to the lens material as I strip it away from the residual capsule. I'm not going to be able to be completely successful here, and that's okay. I can leave a little bit behind and then put the ring in and try and go back and get some more. So just going ahead and doing that here. Realizing that there's a risk-benefit ratio here. If I pull too hard, I'm going to strip away that zonule with very weak capsular support here. You can see the edge of that capsule, and I'm looking closely for any zonular attachment, not really seeing it. So I'm going to go ahead and fill the bag with a viscoelastic here, and then I'll put in an endocapsular tension ring, the Morcher ring. And a lot of times I'll do that manually. This time I'll demonstrate doing it with the inserter. You've just got to make sure it doesn't catch on the inserter and end up stripping the bag. So as you can see, the ring is going all the way around. I'll then try and remove some of that additional cortex. And sometimes the bag is better supported by the ring, but then also the ring can hold cortex in the capsular fornix more. Switching from rather than a plate or a one-piece lens, I'm using a loop 3-piece lens given the degree of pore support. So putting that in the bag here, and then I'm going ahead and using my second instrument to score Descemet's membrane. I'm going to go ahead with the DSAEK procedure, despite the fact that I have this zonular weakness. Patient has such a small eye, I really don't want to have to go back and have to do this again. I'm going to go ahead and do a little bit of a Descemet here with my insertion forceps, and just clean off that area in preparation for the donor material. Going ahead and checking and removing any residual material, and now the viscoelastic. You can see there's a little attempt at iris prolapse there, and I'm trying to keep vitreous and lens back. So I'm going to go ahead and put in a little myostat to bring the pupil down just a little bit. Use the ultrafit tree fines to cut the donor tissue that's been pre-cut for the DSAEK procedure, and this looks like it's going well. And so I'm going to go ahead Remind the patient not to squeeze, and I'm going to slide this in with a straight cystotome under a viscoelastic protection. This has been terrific technique here, and in this case you can see it kind of tries to fold and come back, so I push it out, and then I'm going to use an air bubble to bring it out to full size. And patient did remarkably well. I am a little concerned long term with zonular support, but really looks great.